Implementations. So welcome everyone to the second seminar in our Global Leaders in Implementation Science seminar series. My name is Guillaume Fontaine. I'm an assistant professor at the Ingram School of Nursing at McGill University and director of the RISE Implementation Science Lab. It is really my great pleasure to introduce today's speaker, Dr. France Légaré. Dr. Légaré is a full professor in the Department of Family and Emergency Medicine at Université Laval in Quebec City and holds a Tier 1 Canada Research Chair in Shared Decision-Making and Knowledge Translation, which has just been renewed, from what I understand, up until 2030. So Dr. Légaré is a practicing family physician since 1990, and she's really recognized as a global leader in shared decision-making, implementation science, and the science of scaling up health innovations. Her research program focuses on embedding shared decision-making into clinical practice through implementation research, including stepped-wedge cluster randomized trials with a particular emphasis on home care and prenatal screening. No small accomplishments. She has secured over 112 million in research funding over the past 7 years, published over 450 articles, is regularly named among the top 1% most cited researchers globally, has been made and named Knight of the Ordre National du Québec, and also received the President's Award from the Association of Faculties of Medicine of Canada for her leadership. So today, Dr. Légaré will present on updates on the knowledge base for effective scaling of health innovations. And this presentation is going to draw from insights from different systematic reviews and randomized trials that she has conducted. So we're truly honored to have her with us today. So please join me in welcoming Dr. Légaré, and the stage is yours, Dr. Légaré.
Hello, everyone. Before I flip to my PowerPoint, I just want to really thank Guillaume, who actually is also really gifted in the field of implementation science. I'm truly honored to be invited by him and also have the opportunity, I hope, to exchange with you. And in fact, my name is on the first slide, if I might say so. But as you will very fast understand, it's the work of many, many people, and I've seen them as far as I'm going through my presentation. I'm based in Quebec City. I would have liked to maybe be in the same room with you all, but I understand that it's not always possible, and that technology offers this great opportunity to mingle together. So hello again, and I will flip now back to my slides and will ask if this is well seen, Guillaume.
Yeah, I still see your first slide.
Okay. Oh, now the second.
Oh, yes, this is good.
Okay, so I'll stay to the second. So the objective that I did explore and discuss with Guillaume and his team and some of my team members here is I would like and hope that by the end of this presentation and our discussion that you'll be able to summarize what is currently known or not about the science and practice of scaling innovation in the health and social services, that you'll also be able to identify some of the few steps, because we've tried to get them from a number of different frameworks. Detail our instrument called the ISAC 4.0, which has been rigorously developed, and its aim is to assess the scalability of innovation in health and social services. And please join the discussion to discuss the potential pitfall of scaling, because we often hear the good thing about, I want to scale, but I think we need to be careful about also some of the pitfall. So how did I get interested in scaling? I thought I would be sharing with you a bit of my trajectory so you understand where I come from and why this got to be into my research program or even interest. So as Guillaume has mentioned, I have held the Canada Research Chair since 2006. So next year it will be about 10 years. And when I started, it really had the focus of implementing and getting the participation of patients into the decisions making, so they could actually reach a informed, value-based decision about their health. So that has always been some of my focus, but as you will see, it has modified itself through the year. So that had been at that stage. And to make it a little bit more detailed, if you look at the bottom, and I like sometimes refer to those dolls that you can put in one into the other. So when I started around circa 1995, much before I got into my PhD with Annette O'Connor at the Nursing School of Ottawa, I actually worked with her. So we actually translated and filed in a randomized control trial a decision aid about hormone replacement therapy. So we would be able to demonstrate, as it was known with other trials, that decision aids, when patients are exposed to decision aids versus not, they have a better decisional comfort with their decision and they have less decision tree. But discussing with Annette O'Connor at the time, she was already a Canada Research Chair in decision support at the University of Ottawa, and I want to say hello to her because she's been a great mentor to me. She was already saying, we know the impact of decision aids, but, we have a hard time to get them within the trajectory of care or in the clinical practice. So she invited me to join her as a PhD student in 2000 and to actually focus my PhD research project on trying to actually implement, so increase the uptake of decision aid within primary care clinical team. That was, again, very fortunate, I'll name many people, to actually do it alongside my great friend and colleague, Dawn Stacy, who at the time was doing her PhD, also with Annette, but implementing decision aid in the nursing clinical triage phone center. And also to have the great pleasure to mingle and get to know Jan Graham, a outmost expert in knowledge translation, and get to be a little bit more aware of the content. And then when I got out of my PhD, I had realized that although we knew and had some of the tricks to increase the uptake of decision aid and decision making within clinical practice, and by the way, we're still in charge of the Cochrane review of implementing decision making in clinical practice, we needed to pay attention to something else, which was increasing the coverage across a larger number of clinical sites. So that's where I got some of my interest. And while I was mingling with Jan Graham, as I say, one of our utmost knowledge translation experts, Jan already had reflected on his knowledge to action framework, which actually was published in 2006. But when I was in Ottawa, he was already, talking about it. And for those of you who know it very well, and I think, Guillaume, you've been very clever because you have adapted it lately, is that if you look at it, you don't see scaling. So by the time you get from the, producing knowledge and getting it into the applied world, it gets to evaluating outcomes, sustained knowledge use, but there was no scaling. And when I was discussing with Jan at the time, he was telling me that when they created this knowledge to action overarching framework, that was out of middle range theories, that scaling at the time was not something that had been strongly presented in the material. So that was one of the reasons. So that got me again more interested and curious. Thus, I was again fortunate enough, and I want to thank everybody on my path who have been so generous to me. And also, as I say, I'm here as a person, but everything I'm presenting is a large group of people being involved into this. So Nancy Edwards at the time, she was in Ottawa. And as you know, I think, again, she's one of the key person in population health, coming from the nursing science, invited me to actually go to this conference in Washington in 2010. It was under the leadership of Wynne Norton and Brian Mittman at the time. They brought together a vast number of organizations. There was about 50 of them. You can find them in their paper, where there was discussion about scaling up and spread. So again, I was very much grateful to have this opportunity, because while discussing with all these thought leaders about scale up and spread, when they publish their paper, and I invite you to look at it because it's still very relevant, they, after the few days, had put together a list of recommendations. I'm just now putting the 5 overarching theme, because if you look at the paper, you'll have all the details, research questions that you may want to pay attention to. But basically, we got out of that large meeting saying, no, we need to increase awareness about the need to look at scale up and spread. We need to, as this morning, increase exchange and collaboration among all of us who are interested into this field, develop and evaluate the methods, the intervention. I mean, there's a lot to do. Have new approach for evaluating scale up and not confuse it with other type of outcome assessment, and expand capacity. So in our field, it means training the next generation and the trainees into this field. So now, when I then started, and again, there's so many people involved, so I'll name them along the presentation, started to get a bit more curious and wanted to know more. So we started to do a number of systematic review, or even do some descriptive work and also trial. So that's a list of all the team's members. Most of those been led by the trainees, so postdoctoral student, master degree student, and younger investigator, just to give you a scope. So I'll start with what we find is one of the most achieved aspects of trying to get a sense of what's out there. So this paper has been led by Roberta Corora, postdoctoral student with us, but also Karen Plourde at the time was a research associate with us, and a vast number of people that you may also recognize. I'm thinking of Amédée Gogovar, Ali Ben Sharif, Hervé Zoumaong, Andrew Mila in Sydney, and Luke Wolfenden also in Sydney. Very good friend, I think, of you, Guillaume. And that was a review of the review. It's now has been top-cited, identified. So that was a humongous piece of work. It was done during the COVID. And we were able to locate about 137 unique reviews. So we're talking about reviews, not trials or studies, and 146 reports. You can see here very, I would say, can see it, like it's easier than just say it, that across the years, there's been an increase in publication of reviews. Again, I'm stressing reviews, not only studies or trial. So obviously it means that there is great interest in the field. And what we were trying to achieve was also, as I say, it's a very high level, of what's going on. So what we did when we found out the review, and a lot of people were involved, was to try to categorize them in terms of major themes that they were addressing. As you can see, everything that tap into theoretical framework, 24 reviews, barrier and facilitator, 29, intervention, 37, and scalability assessment, 24, were very much present in the result. However, as far as cost or infrastructure, even measurement of scaling, that was less observed. And finally, I want to point this out because we're in a society that I think now pay more attention to ethics and societal issue. There was only one about ethical, legal, and societal issue. So that kind of gave a very high level signal of where people have not maybe invested that much into trying to get new knowledge out of this, and where it's been already very much invested in. Interestingly, when we looked at every of those reviews, scaling itself was not always defined. Only 36.5% of the review presented their definition of scaling. Interestingly, sustainability was often very much mentioned, so almost like, and I think many of you know about some of the tools that get both together, sustainability and scalability. We've seen it in Jan Graham Knowledge to Action. It was there. So this idea that it goes together is certainly very attractive, but what I'd like to highlight is that those are two different concepts with two different definitions, but they may very well be complementing each other and be together. And then very few had developed a tool of some sort, or worth mentioning about developing a tool as the outcome of the review itself. Then, as far as the scaling domain reported on were also present, and we're building on the work from Ali Ben Sharif, who had devised, I'll show it a bit later, a way of categorizing the type of intervention that can be used to scale. So either you tap into the healthcare infrastructure or the policy regulation, the funding, financing, human resources, and patient public engagement. You can see that at some level, either at the barrier of facilitator intervention, it varied across those 5 categories. Also, what we got out of this is, in terms of the outcomes reported, it was not very often that we were able to extract data about cost, or that the review itself extracted data about cost, or if it's not data, at least an interest in cost, even if it wasn't the major team of barrier and facilitator, so didn't pay that much attention to it. Feasibility, acceptability, fidelity, so again, and sustainability. So again, it gives you a sense of where the main author of the reviews paid their attention. So that gave us, and for many of our trainees, some insight. And as you know, life is not linear, so we had already done some work, or were doing some work, but it certainly gave some more insight to some of the trainees. So I'm insisting about the capacity building to where it would be worthwhile to invest for their next research program, line of project, and research question. Sorry. So now I'll start talking about the way that now we have a vision of this. So we took upon the word scaling. So that's what we've been using. And I want to thank Robert, the IRDC in Ottawa, because he brought us the idea that, when you scale up, it's almost like one way. But as you know, in our field of implementation, de-implementation, you have something similar in scaling. You can scale up and you scale down. So we're using and referring to scaling. So a deliberate and systematic evidence-informed process whose aim is to increase the positive impact, obviously, of an innovation that has proven effective for improving quality of care and the welfare of individual and population. In terms of type of scaling, so we took from the WHO and ExpandNet network, so know please that WHO, the World Health Organization, has a specific group interested in scaling called ExpandNet. So they've devised a number of tools and guidance. So it's one of the multiple framework out there. But interestingly, they've devised or defined that you have horizontal scaling, a bit more like the spread, vertical scaling, so you go up into the policy and regulation, also spontaneous scaling. And I don't know if some of you are from the Collège Québécois des Médecins de Famille, the Quebec College of Family Physicians, but we've seen some of this type of initiative where somebody has a great innovation and there's no specific a priori guidance, and it suddenly start being scaled spontaneously. So it is recognized as a potential type of scaling. And while we were giving some of our workshop last year, some of our attendees even brought in a fourth type of scaling that they call the forced scaling, specifically so in the healthcare system when you feel that there is a top-down approach and the clinical teams understand it's about scaling, but they feel it's forced on them. So we didn't put it there, but we've heard it from the clinical teams. We also came across, again, with Robert McLean and his colleague Gargani, very good book that you can download free in both French and English on the RDC website, called Scaling Impact Innovation for the Public Good. That's another framework. So I invite you to look at it. So scaling up for them, and they have a way of showing it. It's like you have an apple tree that produces trees, and you just boost the apple tree so it produces more apples. So that could be actually a national center for training, and they produce trainees, but suddenly they get upgraded and it stays as it is, but it can produce more trainees, or actually, care about more patients because they open during the night or whatever. Scaling out would be you have multiple smaller centers that you spread across a jurisdiction, but they still have about the same number of apple or patient or trainee that they produce. And scaling deep would be that this center actually get enriched in another type of way, because not only do they train some people in a very specific field, but they train in multiple other aspects. So people actually, get as larger apple because they get out of it with more, I would say, capacity in their training, because it wasn't focused on one specific thing, but has other aspect of it. One of the potential ideas is pay attention, more equity and vulnerable people. So it's almost like you have no more apple, but they're bigger and more enriched. Some of the nuance, because all of you have a great interest in implementation science, so you would have read about all those papers, and the idea that diffusion is not the same as implementation, which is not the same as scaling, and as I mentioned earlier, not the same as sustainability. And again, you can read all about these concepts in the cited paper down there. Now, when you look at the number of a framework, because there are multiple frameworks out there, here what we actually decided to maybe use as a overarching framework for the steps is the guide from the New South Wales, Australia, where Andrew Milat, one of the outmost experts in scaling in the world, I'm sure of you have come across some of his writing. So he is very influential. So that's where we got this out. And again, as I say, it's very aligned with other framework that we've also read about during our reviews and work. So first you have to identify the innovation to be scaled. And I'm not going to go into all the details about this, but this is one of the most confusing aspects. And if ever you can talk to Ali Ben Sharif and Elvis Amaoun, when some of the review were created with those two wonderful individuals, identifying what it is to be scaled, okay, is very important, because there's a lot of confusion, especially if you refer to the PICO question, the PICO question, what is the E about? Because in our interest field, it's about the I, or the I said, sorry, the I, PICO. The I is about the intervention to scale. It's a scaling intervention, but we all understand it's scaling something, which is the innovation to be scaled. So that's what we've had a lot of trouble in doing. Some of the work we've done, and we're still having it, is to distinguish the innovation to be scaled. Because then after that, you're going to distinguish what is the intervention or the strategy, the I, to scale. Then you have to evaluate the scalability of this innovation, and we'll see a little bit more in detail what this means. Based on your previous step, develop a scaling plan. So it's a priori, prepare for scaling, and then scale up the intervention to be scaled, and obviously evaluate. And in a perfect world, learning healthcare system, monitoring the scaling over time. So it's not a done deal forever, but what's going on over time. Here, a bit more of, I would say, operationalizing those steps. So for the first one, we'll show it a bit later. We have developed a tool that can help you identify the innovation to be scaled, because again, I cannot stress it enough. And for those of you who've been in that field for many years, it's even the birth of the field. When people like Jeremy Grimshaw and others, when they were bringing a new editorial group in Cochrane, the Effective Practice and Organization of Care, is how do you foresee what the I is? Because the I, knowledge and implementation, is usually not a pill or a treatment. You know what I mean? So they were strong enough and visionary enough to convince us all that the I was an intervention to translate new knowledge. So here, pay attention. It's something similar, but it's about the innovation to be scaled. Then evaluating the scalability, I'll show you a bit more in details. Developing a scaling plan, obviously engage stakeholder and user, prepare for scaling, consult with stakeholder, legitimize the chain, etc. Scale up the intervention, carry out the scaling. Some of the work in the past that also has been very influential was by Dean Fixon, who did some of his scaling, most of his scaling work in the education with school system. So maybe pay attention to how you put together your scaling things. And then, as I said, evaluate and monitor the scaling and pay attention to a vast and large variety of outcome measures. Scalability assessment, so we'll go into more detail about the tool that was developed by the team, a very large team. And it's a bit about, I find it has some similarity, not in the content, but with the famous maturity index of a technology. When some of you, applied for a Ministère de l'Économie and Industry grant, where some of you will, have to defend the idea of what is the maturity index of a new computer or a new MRI, whatever. But here we're a bit in the specific domain, which is the scalability assessment. So what is the importance of the scalability assessment? I mean, it puts it very clear in your mind a priori that this is what you're aiming at. You need to justify why the innovation that has singled out needs to be expanded, replicate, or adapt. You need to pay attention to the potentially, benefit, but also the harmful impact of it. And I guess we need to be humble all what we've tried to do, because you and I know that for, let's say, trials again of medication, I'm sorry, I've been a physician for 85 years and still am. We sometimes have said, the trials for medication do not report enough harms because they don't measure harms, and then we push for that to be reported. Well, it's the same with knowledge translation or scaling, etc. We cannot pretend or pose it that it's always going to be only the positive impact of the innovation that will be actually accelerated or increased. So we need to pay attention to that. If it's acceptable, the resources that it will require, etc. And if there is enough knowledge then about the innovation and the new context to undergo successful scaling. So the tool, how it came to life. So again, I'd like to praise the work by Ali Ben Sharif, who was a postdoctoral student with us much before the COVID, and then a bit during the COVID, and Liz O'Mahony at the time, who also was very crucial in starting the Quebec Sports Support Unit with us. So what happened was, it's really, I find an interesting story. So about circa 2017 or about, some of you will have experienced the fact that CIHR had funded 12 teams to engage into primary care research and innovation. And by the end of the process, they had to present every one of the teams their innovation and result. And actually, the desire for them, it was expected that they would scale the good innovation they had developed. So I was again fortunate enough in a meeting in Toronto at the time where I would see the room was packed with the 12 teams or about, and on the stage there was a policymaker from I would say 5 to 6, maybe 7 provinces of Canada, even maybe territories, and everybody in the of those 12 teams were presenting their work, saying you need to scale what we've produced. Interestingly, many teams had more than one innovation they had developed during their 5 years funding. So can you imagine the policymaker having to devise a way of, among the maybe 60, I don't remember, so 12 teams, let's say 3, 4, 5 innovation per team. So there was a revelation that there was maybe a need to try to see what was the most mature to be scaled up. So that's how Ali Ben Sharif, with the Quebec Sports Opportunity at the time, devised a way, looking at some of the work he had already done, to create a first tool, which you see the archaeological aspect of it, so the very first version in August 2017, and he used it on those things. So again, I thank them all. And used it also with the Collège Québécois des Médecins de Famille to actually try to see if, it can be applied and inform us. So that's out of necessity, but out of these work by Ali Ben Sharif, we also decided that we needed to do it the right way, which is a systematic review, been published, and then the EDEL5 process to basically get to the ISAC 4.0 version that you can download on the Quebec Sports Opportunity, and it's available in both French and English. So the tools itself, as I said, has been developed with systematic review. You can see all the details in the publication, and EDEL5 process. So the tools, you can access it, and we'll go through it a bit, so you can have a sense of its content. But again, I invite you, it's free, to download it and have a look at it and see if it can give you some help in your work. So obviously, it has an introduction, and it presents some of the concept and definition, now also how it was developed. What you will find into the tool itself, or the document. Again, it was very iterative, and I should stress the work by Roberta Coroa, but also of patient partner and the individual who work within the Quebec Sports Opportunity. So there was a lot of iterative feedback loop to get it the way it is. And because life is very dynamic, it's called 4.0, and we're very much convinced that it will change again at some point as people use it and make comments, and we integrate their comment. Glossary, where you can also get a bit more insight of what every word you'll encounter or concept is defined. And then there is, as I mentioned, a way to try to help people to identify the innovation. Because again, this is extremely important, and I won't stress it enough. I've had this difficulty myself, so I'm not an expert in anything, but I'm certainly is a long life learner. And again, is what is it that you really feel that is distinguishable and scalable? Because obviously, if you have a tool that you can take in your hand, so let's say one decision aid, be it in a paper form or even online, it's kind of very distinguishable. But then when some people come and they say, we have this process where, you would have a nurse evaluating a patient, and then you would have somebody else do something, and then you would have a training session, and then you would have, then where is it? Are they actually putting together what is being scaled up with some of the scaling strategy or large-scale implementation strategy? Or is this the whole package being the innovation to be scaled? So again, just pay attention to it. And some of the work that we've done, we've used the tidier by Tammy Hoffman and others to try to distinguish the innovation itself. But again, as you will understand, I'm stressing that this is no small endeavor to identify what it is that you want to scale. Components that were actually found in the systematic review that identified multiple scalability assessment tools and identified all the component items, etc. And then eDelphi and those that were kept. So you see them here. In fact, you see 12 of them because out of the systematic review, there were 11, but there was one that was added by the. What we also have done, and I'm confessing it because in research, there are a priori research questions, some a priori hypothesis, etc. Other times you go with, what needs to be done. And at this point in time, what I'd like to confess about is that this is not a tool with a measurement component where you could do factorial analysis and say, there is a score that, is out of, and if it's above, yes, you can feel that it's going to be scalable or not. There's nothing of this. However, we felt or thought, and then we had good feedback out of this, that to have a scale of some sort, in this case, a Likert scale, so people could reflect and respond within themselves or within a team that they strongly agree about the item or not, could be useful more in a qualitative way. If I'm using it with some being careful. But again, I stress that this is not to be used as a mathematical aspect where you could devise a score. Now I'm calling for anyone interested that there could be some more work to be done to look at the response scale if this is actually desirable and feasible. And when to use it. So this is a that's it, a scalability assessment tool. So yes, it would make sense it's done before scaling because it can help you devise what needs to be done before even you plan your scale up as such. Or actually you're ready for scaling, but you still need to pay attention to some aspect that this tool has informed you upon. As I said, it may also be used after scaling, if we can sometimes stop it in a precise time frame and see ongoing if things are also evolving or not. So this actually is quite flexible, and we have, let's say, we have experimented this with a team here in Quebec, Patrick Archambault and Laetitia Burke, who've done some very good work using it with the response scale and ongoingly, and actually found that it was their project to being conducted. Now, as I said, it would be, easy to say, and especially in our era, I think we all understand that we're going through some uncertain time, and it's still challenging for many of us or of our citizens. So that, we've solved the world problems and that everybody, like the end of a fairy tale, like they lived forever happy, etc. Had multiple kids. But that's not the case. I think we need to pay always attention to the pitfalls and what is it that we're kind of moving forward that is used, we hope, helpful, but what is it that you need to be careful about? So before I get into Hervé Zeman's paper, I'd like to share with you, and I've shared it with you, Guillaume, some of the work that's been done by one of our team members here in Quebec, Diogo Moshkovich. So Diogo is a philosopher by training, A-level training in philosophy, and he's also has great expertise in bioethics. And he brought us back, to looking at, what we call being ethical, because it has to do with not something very sometimes unidimensional. Basically, ethics is a world in itself. It has a S, multiple S. There's multiple type of ethics that you want to take into account. So when you say it's ethical, you're basically saying there's temperature outside, but you're not aware if it's cold or if it's warm. So again, I want to thank Diogo for his insight and for all the work he's done with us. So either you go on the one way which is teleological and you look at what's happening after you do something, or you do it without looking after what's going to happen because you have to do it. So those are basic intention. And as again, this is a very simple tree here because this could be only, I would say, detail. But on one hand, which would be the teleological, when you look at what's happening, basically you're looking at the principal aim and what are the impact. If the impact are bad, then you don't do it. On the other hand, if you look on the right, you do it anyway, and you don't look at what's happening because you need to do it. For example, this whole charter for Canadian or your deontological code from the nursing profession or medical profession. So very much tension and again, very detailed if you look at it in Diogo work. The other thing I'd like to point out is also work by Roberta Coroa, so a systematic review of patient and citizen involvement in scaling. So again, what we got out of it is that, yes, this is sometimes happening, but yet it's very much at the lowest level of engagement, and we need to do more. So what are the potential pitfalls? Because I wanted to lay the ground for those different aspects, patient engagement and the ethical aspect of it. So again, I want to thank the work by Hervé Zeman. He did a wonderful work at the time. It's a rapid review, if I might say so, where we were only trying to look at the pitfalls. Basically, that's what we were looking at. What could get wrong or what could be wrong about scaling. And Hervé found exemplar for each one of those pitfalls. So I invite you to read this paper. It's free, open access. So there could be a cost-effectiveness estimation pitfall. I think that everybody nowadays may have a little bit of an eye on the newspaper and it's going up and down, up and down. So basically to estimate how something will cost in the future is always extremely tricky and most often not perfect. So there could be definitively a huge pitfall here when you say, I'm going to scale and I know how it did cost for, and then it costs about, then suddenly the bank is breaking. Then there are inequities pitfall because you may be able to scale based on what you've seen with few sites or some sites on some type of population, but some vulnerable or person did not really get the benefit out of it. But as you're going to increase and scale, you may even increase, and now you will see it. So again, that has to be taken into account. And again, I invite you to look at Hervé's paper because he mentioned and cite real research that show that happening. Then there is the scale harm pitfall, what I mentioned at the very beginning in knowledge translation. Obviously, none of us want to implement something that's not evidence-based, that's not desired by the population, and that's doing harms. I mean, I think I don't need to convince you of this. But to be not reflecting upon the fact that, as other fields of science have shown, you sometimes have harms or collateral effects that are attached to something, be it a treatment or an innovation of some sort. So if you scale an innovation, you may scale its harm. Please make sure you have documented them at the start, and also be ready to understand you may have collateral impact that you have not thought about. Ethical pitfall, exactly why I wanted to show you the work by Diego, is there's some work that's been shown, especially, and I should have mentioned it, that the science, probably the practice of scaling, is very much developed into the global south, in lower and middle income countries. High income countries are not where we've seen the most knowledge out of all the reviews that have been published, not even only our work, but the work by colleagues across the world. So I should have mentioned it, keep it in mind. So in some of the work of scaling innovation in some lower and middle income countries, especially work around HIV, AIDS, there are multiple ethical aspects out of it, and sometimes people have been struggling with the fact that they were trying to do good, but they would not have consent of the population. Confidentiality was not protected enough. So the ethical pitfall was not unavoidable. Then there is the top-down pitfall. And the top-down pitfall had to do with the fact that the tension between the bottom-up and the top-down that we've heard about before. So this whole idea that it comes from above, somebody or a group of people say, this is what we need to do. And then the end user, I might say so, that doesn't meet what they wanted to prioritize, that doesn't meet their needs, and they don't necessarily embark into that journey. And then the contextual pitfall, what we've seen in some of the review, and Hervé mentioned this, is much of the work that's been done to draw knowledge out of it and show maybe how we can do scaling has been coming out from the low and middle income country. Most of the authors have been based in high income country. So sometimes there's been a mismatch between some of the context within which it seems to be happening effectively, but then transferred to another cultural context, it did not have the expected outcome. Lever for scaling. So again, Ali Ben Sharif work, the review by Roberta. I want to congratulate and again thank Ali for the work he's done. So 5 main levers that we were able to get into that type of theme analysis, thematic analysis, and out from the paper from Ali for primary care, 14 studies, you see that the one that had been the most used and reported upon and used was human resources. So train the trainer, train people, human resources. As for involving patient, it's very much at the beginning, although Roberta in a review that's specific to it found some report, but there was no studies at the time in primary care. And then you would have the infrastructure, so setting up innovation center or what we're doing here in Quebec, le Bureau de l'Innovation or the different entities in our healthcare system putting in innovation center within their organization would be more at the C1, and then policy regulation and funding. Just another word of caution, if I might say so. So when we were doing the review of the review with Roberta Coroa, there was a paper that was very interesting because it was talking about what would be some of the best trial study design, so at the time, to actually do a scaling studies. Again, I'm saying out of one paper, I'm not pretending it covers everything, and obviously it could be mixed method. But in terms of study design, and it was a step wedge, because you unroll or you roll out an innovation, and you roll it out after you've been very careful. It was evidence-based, obviously, but you roll it out. So by the end of your trial, in contrast with a randomized control trial or randomized cluster trial, everybody has gone through the innovation. So we've done 2 of those. That's our second one right now, only preliminary result, just to give you a sense of what we're trying to capture. So it's within a larger project led by François Rousseau here at Laval. And basically what we tried to do was to scale up decision age making across all clinical sites in the province of Quebec that pretend to do follow-up of pregnant women, so prenatal. So really started, it was a long process, and it's not perfect, please be indulgent. But by identifying how many clinical sites distinguishable in the province of Quebec could pretend that they provide prenatal care. That was, at the time, there was no registry of this, so that was quite difficult. And we went down. And by the end of the process, we only recruited 32 because that was what we needed for the power of the study and also the budget we had. But we had a sense of, out of those we had contacted, we had a positive answer in terms of, yes, we would like to have this happening. So indirectly on the right to have coverage, I say indirectly, the study design on the left. And by the end of the process, as I said, this is preliminary result, you get this type of a figure showing how it has evolved through the process of the study, because the randomization has to do with when the time clinic or cluster gets into the study, and not with, two arms who gets it or not. But again, the reason I'm showing this to you is at least there was one paper reporting that when you want to do a trial of scaling, step-wedge are at the time were recognized as the, I would say, preferred or best way to do this. More resources. So with the Quebec Sport Support Unit, and I want to thank the team at the Quebec Sport Support Unit, so the central. As you know, the scientific directors, Antoine Gros, Mylène Lévesque, Mira Drolet, France Lemieux, who have been very supportive of this type of work, and the people who have done it, so Odilon, Hassan, Claude Bernard, Oscar. So we, with a committee of 20 people representing different stakeholders, have produced 2 online training open access modules. One is on scalability assessment, so it's free, you can just go and do it. And one about how and why engaging patient and citizen in the scaling process. I'm very sorry that currently we have it solely in French. It's been a very, very long process, and I'm not shy to tell you that for each one of those, with a committee of 20 people, it has taken at the minimum, and it's online, so there was somebody who was dedicated to this online, it has taken more than a year. And that doesn't include the work like systematic review or what we have to do. So it's been extremely long, firstly. So we didn't have the budget to translate it in English, but I'm making a call to this wonderful community. We have the license, it's public, so if anyone or organization here would like to take it and translate it in English, we would be more than welcoming this proposition. But again, as I say, it was a lack of budget right now and time that hamper our capacity to do so, but you're invited, you want to do it. Lastly, the Quebec Sport Support Unit and the people I mentioned are there to also answer some of your questions or even service you if you'd like to help you reflect on scaling and innovation. So please don't hesitate to reach out to them. I'd like to mention, as I said, I've named many people. So if you go through the slides, because the slides will be public, you can find out all about the other people that you can also reach out to because they have great expertise. So thank you so very much. This is the team, I would say I think it was 2023. It's very dynamic, but some of the people you see there are still with us. So if you want to reach out to us, we are very happy to try to help you. And if you want to come visit us, 2-hour drive from Montreal, you're most welcome. So thank you so very much, everyone. I'm now stopping and can engage with some of your question or discussion.
Excellent. Thank you so much. This was a fantastic presentation, France. May I call you France, right? Instead of Dr. Légaré?
Yes. Okay. No, nobody calls me doctor here. Everybody calls me France.
Great. So if you have questions, please type your questions in the Q&A section of the chat of the Teams meeting, and I'll ask them to Dr. Légaré in order of them being asked. While I wait for some questions to arrive in the chat, I'm going to start with a few questions of my own. Really, I love the overview that you gave on the trajectory of your work, France, and also how you define scaling, the different steps for scaling as well, going into the strategies for scaling, and you provided along the way a number of tools and resources. And this is really, I think, going to be appreciated by people attending the seminar because they can go in and directly apply your work. So bravo on that. So I guess one of my first questions is around the questionnaire, right? The ESAC 4.0 questionnaire. Can you talk a bit more about who would fill out the questionnaire? Would it be, the healthcare providers at the site, the researchers, other people involved? What do you recommend, and what has been your experience in terms of engaging people for this tool?
So thank you for the question, Guillaume. And again, I'd like to invite everybody not only to ask questions, but bring your own insight and also knowledge, because everybody, I'm sure, attending has his or her own knowledge. So please come on board to share it all. So I would then like to invite you to pay attention to the 2 online modules, because that would partly answer your question. So the 2 online modules are not only like few slides with some, I would say, didactic presentation of the material, but it draw upon Patrick Archambault work with Laetitia Burt, a PhD student, who is gifted researcher, clinician, and researcher, where while they were scaling a innovation for older adults and their caregiver consulting at the emergency room, they had engaged with the caregivers, patients, citizens, policymakers, etc. And in fact, they report, well, look at go through the module, how they've used it, with inviting everyone in their team, because there is a large team with all the stakeholders who want to reflect with us upon those elements. And so it's really for either the innovators or the knowledge implementers to decide and to offer it. So when you listen to the online training module, there is a woman, she's a caregiver of an older adult with dementia, and she has been exposed to the tool, and she tells you how she reacted to it, what she got out of it, if it was difficult. So there's no, I would say, exclusion criteria, if I might say so. But I think it's for everyone involved in such an initiative to invite whoever they feel they should invite and see how these people feel about the tool, because the tool is also what we heard from Patrick and Laetitia team is a strategy to talk within the team what's going on as a scaling process and how everybody understands it and where they have difficulty or not. So there's no exclusion criteria.
Right. Okay. This is very interesting. And what was in my mind as well when you were presenting the tool was that it could be used to compare and contrast different innovations between, for example, I do a lot of research on testing for infectious diseases. So we're going to compare different testing modalities and how these might be scalable and kind of, because you mentioned that there's not necessarily a specific threshold or cutoff as a score. But if you're comparing and contrasting the scores or like the feedback that you get from the questionnaire between different innovations, then that could also be really quite interesting, right? As you were saying, multiple teams considering different innovations to be scaled and so on. So that would be quite interesting.
Yeah, and what Laetitia said that was helpful for them, because again, it's not to be used yet. Who knows with the world in the future as a given factorial analyze tool, etc. It's not done, but what it gave them was a capacity to say, okay, you score 7, I score 1. Why is this? So it opened a discussion. It's more like opening the discussion, trying to understand. What also Laetitia found out in her PhD is when you apply it longitudinally, you can see if people change their not only their score but their understanding. So what you mentioned, Guillaume, is yes, it could be used by, I would say, I wouldn't call them funding agency per se, but by, let's say, high-level policymaker who would like to see which innovation may be a little bit more mature to get into scalable process.
Scalability process, yeah.
It could be, like I say, the maturity index. When you do a project with the industry, Ministry of Industry, you need to have a specific cutoff. Which is the case here. And then it could be used by people who want to do this and see where they need to pay attention to.
Okay, we're going to get into the questions. So we have multiple questions.
Yes.
So we're going to go through them. Okay, so a question from Melanie Barwick. The naming of the intervention to be scaled is often not sufficiently detailed for the implementing organizations to know what must be put in place to deliver the intervention, what we call the core components of the innovation. The ESAC tool doesn't get this, although it often asks other key questions. So do you have data on the tool's usability? That's
very good question, Melanie. Hello, I hope everything is going well with you. So very good point, because as we know, not only a day has 24 hours and a week 7 days. There's so much you can achieve in a specific time. So this is why I did mention that maybe it could be coupled with Tidier to present in more detail the innovation. That would be something. And we don't yet have more usability data than what I reported in from Patrick Archambault and Laetitia Burt work that actually are embedded into the module, as this would be interesting if somebody took it as a research question. However, what is interesting is since we've put the training module on the Quebec Sport Support Unit, it's been the most visited page of the Quebec Sport Unit since it was put online. We do have data on this. So it's very indirect. Then we got a request from Netherlands. A Dutch KT researcher wanted to translate it in Dutch. We gave the permission. And we have not yet, as we've done in some of our other work, do a it's too early for that. A systematic review of whoever cite this type of work. That's a very, very good question, but those would be where I would go to try to get some information at some point, or a wonderful PhD student or postdoc who would like to undertake this as a work. But this is extremely important. Thank you very much for the question.
It's great to know that it's been the most accessed page on the website, and that says
since
a lot.
Since it's been put on the website, that is in French, and also we got a request from Dot, because sorry to say that was not the reason for me to present today, but we've developed some measurement tool in the past with the whole spectrum, going to factorial analysis, etc. Then we've done systematic review of who've used the tool, but this is too early now to get into this. But maybe in a few years, we'll see. Who knows? We'll see.
Sounds good. Okay, next question. So we have a question from Sahar Saeed. Thank you for your presentation. I really appreciated your emphasis on the importance of clearly identifying the intervention that will be scaled. Do you have any advice on how to distinguish between the intervention, the innovation itself, and the scaling strategy? I find that in practice, the line between the two can be quite difficult to draw.
Excellent question. And unfortunately, I'm not going to be the best person, because we still have a hard time to do this. And we've seen it lately in some of the other work we've done with, let's say, a team that was asking us to help them to scale. It's extremely difficult. And sometimes, in fact, now I'm just think tanking with you, okay? It's not evidence-based. And also, please bear in mind, I'm a clinician, still see patient. So sometimes you need to do what I would call grieving with the innovator team, because they get a lot on their plate, and they say, you need this, and this is the innovation. So it looks very big, you know. There is a training, maybe an online training module, then there is an in-person training, and then there is a booklet, and then there is a grid. There's a lot of things. So, yeah. And I think it taps into fidelity of the intervention. What is the core component? Sometimes we've observed, or we believe we've observed, that people will downsize and say, okay, this is the core component. That's what needs to, to be identified and cornered, because that's what's effective. We need you and I have done a lot of PT work with clinical teams, and we've had to negotiate. And this whole idea of acceptability, yes, or fidelity. What is it that a clinical team asks you not to do? And you say, that's fine. That was, just in case you wanted to do this, but that doesn't really get into the core effective component. And other times teams would tell you, we don't want this, and you'll say, no, I'm sorry, this is not negotiable. That's my. So I think it's a work of, especially in the type of work we do, because again, if you have a machine, but when it's processed, embedded, and it has to do with the process, that's where it gets. And I think it's in itself a wonderful research program for someone, but you need to iteratively try to corner down. But I don't have a specific way to tell you how to do this.
So it's a kind of a give and take process with the team, and kind of looking at defining the core components and going down to the active ingredients, right? Yeah. From what I understand.
Yeah. And see what's really the non-negotiable.
Right. Next question comes from Leonie Matteau. So she says, I have taken the LRG training. Thank you. It was very interesting. My team has a question. So in the context of an international scalability assessment, what would be the unmissable indicators, components of the assessment?
That's a very good question, and I congratulate you for taking worldwide healing studies. I like sometimes to get back to what Ali Ben Sharif did very fast in what I said out of necessity, because obviously what I saw, when I was in the room in Toronto, is obviously policymaker, and it's even more true right now, or even more difficult right now, cost. Very, very rarely innovators have a good sense of the cost. And that's sometimes what distinguishes one team out of everybody else, because they have paid attention to the cost, and because they need the policy and the scale up. That is something that policymaker, that what I've observed, pay attention to. So that could be one aspect. Obviously, the impact, the benefit impact. But what may be tricky, but not impossible, and depending again of the innovation itself, is the cultural aspect, the context, etc. Because what we've seen was the most, again, that was published and that was quite insightful, comes from low, middle income country. Please bear that in mind, because we're not the only one that have said this. And the context, usually like Africa, for example, or even South America, are very different, and they do it within this type of LMIC country. So that could be also something to be careful about. And my third and last, I would say, comment out of your question is, please pay attention to the table of participants at the 2010 meeting in Washington, D.C., because the Bill Gates and Melinda Gates Foundation were there. The McKinsey corporate consulting firm was there. So why I'm saying that is, you may have capacity to connect with other people who've done worldwide scaling. And I should have put it, but I'll try to, I don't know if someone of my team is attending, but there is a community of applied people and scientists based in US that only do scaling meeting. It's out of the ExpandNet people, Laura Gibbon, and they meet every 1 or 2 months, and they do most of their work in low and middle income country. But again, they're doing across many countries. So what I'm trying to say to you is, there may be other people than I who maybe give you better insight than I, and I'll try to, put this in the chat for you. Okay. But thank you for your question, and good luck for your work.
Thank you, France.
Sorry, just one thing, because she's talking about worldwide. So maybe what I would do if I was in the worldwide scene is I would pay attention to high income country, HIC, so OCDE country, and LMIC. I think that's where you're going to have the most contrast. That's what I think.
Yeah, that makes a lot of sense. Next question comes from the Associate Dean of the Faculty of Medicine and Health Sciences, the Director of the School, Lynn McVeigh. So she says, thank you for a great presentation. With many years of experience in the Quebec healthcare network, leading operations through several mergers of healthcare establishments, I am interested in C12 sustainability, the sustainability portion of the ESAC questionnaire. Are there research studies investigating healthcare mergers and their impact on the sustainability of pre-merger scaled innovations, post-merger? Yeah, so that's the question.
Wow, that's wonderful question. Wow, I'm not aware of this in terms of research. And again, I'm not, there's multiple type of health service researcher, but I can think of something out of, but that's a wow question. However, still being in the healthcare system, going through the Santé Québec merger, been 35 years, so I've seen a couple of mergers. So experiential knowledge of the clinician, not evidence-based knowledge of the scientist. There are something that get down to us in primary care that stick beyond a merger or a major change in the healthcare sector. There are things. And usually they're out of necessity. And they're also, I would say, not only out of necessity, but actually attached to the end user, the patient, the people who, as we all know, even though sometimes we say they have not a big voice, but they do have a voice at some point. Because, you know, they get in the newspaper, they say, my father didn't get this, or my father was, yeah. So I've seen things as a clinician that were brought to us and didn't stick, and others that stick. And it seems what I've experienced that stick the most is what was brought and very much aligned with the user needs. But again, I'm very careful here. It's not evidence-based. But I invite you to support research into this. That's a wonderful question.
Thank you, France. Next question comes from Michelle Nelson, who's saying, I have a question about the varying tolerance for evidence quality that would support the first step of assessing scalability. Some community-based organizations may be willing to attempt to scale interventions that are not grade A evidence, but there is evidence that of impact value regarding complex interventions within real-world settings.
Yeah, excellent question, wonderful question. And this is one of the piece of work I was unable to embed into the presentation. So it's called, sorry, if you, please tell me if you agree or not, spontaneous scaling. And we've had a little project that we've done is, and again, please bear with me for those who come from the College of Quebec, College of Family Physician of Quebec. So the College of Family Physician of Quebec for years now have had what they call the Dragon Dance, okay, where they invite everybody from primary care settings, be it a family physician, a nurse, an OT, to come one day in Montreal to present their innovation, okay? It's very popular, it's very highly sought, and they've done a tremendous job. But as you may expect, some people will get there and say, oh, we've created a training, or we've created a way to supervise our resident, and there's no data, there's no evaluation of it. It's just that they did it out of necessity. They had a very good welcoming within their teams and sometimes another team. And then they say, that's an innovation. We had not seen that, so we created it, and they bring it there. So the College of Family Physicians is going to happen in May this year. We'll pick up one or two and try to kind of help them actually accelerate, they call it, or scale it up. So what we did a few years ago is there was a wonderful innovation that had been created by a psychologist and a family physician, and it had to do with how do you deal with disability, out of work disability, like you're not able to work because you have a disability, but it's because of a mental health issue, okay? And they actually produce a toolkit training, and suddenly they got asked across the province to give it, and how to, that's it, scale, spread, and have it everywhere. And there was no scaling plan. There was no, and still has no data that, it changed the number of days in disability, the number of visits to a site, etc. But because it was so much of a void, nobody had something to propose that was structured, that it just, was So that's what we did is we asked them the permission to look at how it was going on with no a priori. So it does happen. And probably it does happen because it filled a void that is so essential to fill. And the second comment I would do, I was a clinician during the COVID. I did a lot of clinical work during the COVID. And during the COVID, we may not remember that, but yeah, we were faced with do this today, and there was no big evidence, you know. Don't put gloves. I mean, we've worked without gloves, without masks because it was not good. Then we work with gloves and masks. And so I think out of necessity, the human being just sometimes move on. But in a evidence-based decision-making, car resources, constraint, etc., yes, you would like to have more grounds to say this is good. Sorry, this is has impact. Please remember the ethics with the S. That's another thing. You may have to do something like engaging patient in decision-making, but what if there's no impact or deleterious impact? Do you move away your deontological life? So, food for thought. Very good question.
Thank you. Next question comes from Sonia Semenek. So she says, research to evaluate the effectiveness of interventions to scale up innovations, must require longer-term funding. So what are your recommendations for securing funding for scalability studies and sustainability?
Everybody here, you're wonderful. You have so very good question. Excellent question. Out of experience, not evidence, okay? I read once that everything, even coming from the private sector, needs to have the public funding at some point to be embedded into the healthcare system and be sustainable, okay? So basically, my understanding, experiential, is at some point, and if you look at your healthcare system, again, we didn't talk about this, but the scope of where you want to scale. Because you can, sorry, I should have said that you can scale within a hospital because you have many wards. You can scale within a large city area because you have multiple smaller clinical centers. You can scale within a province, especially here in Canada or territory. Everybody knows that until it changed, we still have the provincial healthcare system. And then within a country and for some of our colleagues in the world. So back into the funding. So my observation, but I've read it at some point, even for the private sector, you need to embed what is so good for the well-being of individual within some type of policy and public processes, which is policy making. And then if the policy holds true until a change of governing body, that may be a way. But what I hear you say, and I've heard other researchers say this, is, oh, I've been receiving funding for 5 years or 6 years, and now I don't have funding left. Can I get another round of 5 or 6 years? You know, we think as researchers that we, being humble here, that we need always to be there to follow up. Question mark to you, food for thought. But again, if you'd like something that you feel is good for the public good, and please have a look at Robert McLean's work at the RDC. The public good requires that the public policy making kind of uptake, and that, sorry to say, you let your baby go.
So, looking at the ownership of the innovation by the system and the public system.
And I've seen private companies, having that website or whatever they have, and actually they all, sorry to say, that's my, again, experiential. I'm not perfect. I don't know everything. they knock at the door of the government or the Ministry of Health, and they say, we have this wonderful, it would do this, it would impact this, it would cut this, blah, blah, blah. And that's where they end up having tried to convince for sustainability and wind scale.
Fantastic. Well, that's we're approaching really the end of our time. So that was the last question. So I really want to thank you so much, France, for your time today. This was a fascinating discussion and presentation. The presentation is going to be posted on YouTube as well for people to access. And we can also share papers that you've mentioned and tools in the email that we'll send to all people that registered for the webinar as well.
Yes, and people can reach out, and I see a couple of other questions. So one from Lynn saying, should we envision a bureau de la pérennisation de la mise à l'échelle, or sustainability of? All very good question. As I said, those are, and please, Lynn and everybody, do a thought experiment, because this is interesting to do. Some things may be and should be scale, but that doesn't mean they should be perennial. Some things should be perennial, but not scale. And then when you get this together. So food for thought, but very good point here. And further, I was wondering, should people fill the ESAC solely on the question they do know? Is the question they do know about? Well, if there are questions you cannot answer, that can actually help you devise where you could put some of your energy in the future if you really want to scale. So very good point. And please come on board, co-construct this all. There could be dimensions that are not there that are very important. So that could be also the case. Oh, I would have liked this question and it's not there. So please, you just add it. So yes, so everybody, thank you so very much, Guillaume, for your leadership. You've done a wonderful job. As I said, we had somebody from Sweden yesterday, and Catherine L. From the nursing school in Linköping, and I think there's so much that you achieve in the nursing science about implementation science. So I just want to congratulate you all, and specifically you. Thank you for your invitation, and please reach out if there's anything we can help with. We'll be happy to do so.
Thank you so much, France.
The
next speaker that we're going to have in this series is Natalie Taylor. She's a professor at the University of New South Wales. She's going to be at McGill at the end of May. And we're going to talk about the difference and the nuances between using theory and using intuition when we're thinking about implementing, scaling up innovations and different strategies for change. So thank you, everyone, and have a good rest.
Have a good day. Bye. Take care.